de la casa, el doctor SWADRON, y su presentación Hemodinamia en el infarto, nuevos criterios. Un aplauso para él, por favor.
Habla más. Habla más.
¿Hablo más?
Yeah. Tell a joke.
El doctor SWADRON va a colocar
Muy
su computador.
guapo.
Es muy guapo, sí. ¿Qué más?
Guapo, inteligente.
Bueno, siempre es un agrado tenerlo con nosotros.
And put the Wi-Fi off. Yeah, that'll get rid of that. I'm ready.
You have the microphone?
I can use this. Do you have the mic? Yeah, give me that.
This one's yours.
Disculpe. ¿Aló? ¿Hola? 1, 2, 3. Ah, perfecto. Ok, es tiempo para un poco EKGs. Okay? We haven't done any cardiology today. Are you excited to do a little bit of cardiology? Are you? Good. I have some good stuff for you here. Right now we're going to talk about STEMI or not. Activate the catheter lab or give thrombolytics or not. This is the question, right? This is an important question. Why is it so important? Because people that need to go to the cardiac cath lab or get TPA do well, and people who don't need it and get it do poorly. It's a very important dichotomous decision. This is a picture of me when I was working on a cruise ship. And on the cruise ship, it was a descuento, it was a budget cruise ship, cheap, with a lot of people from the southern United States. And I remember specifically that they liked to dance the Macarena. I remember that. And they liked to eat all day. And on this ship with, lots of passengers, 2,000, 3,000 passengers, they have one doctor. That was me. One nurse, she was also Canadian. Drunk. Baracha. So when you're in the middle of the ocean and someone has chest pain and you have one EKG and one bottle, at that time was streptokinase, you have to be very careful with the way that you interpret the EKGs. That's when I became so impressed at how important this topic is. But nowadays, and it's the same, of course, in Chile as it is in the United States, we are under increasing pressure to get it right all the time, or as much of the time as possible. Obviously, it's extremely expensive and wasteful to call in 6 people on a team to do a cardiac catheterization at 3 in the morning when it's not necessary. And it's equally tragic when someone needs emergency revascularization, thrombolytics or cath lab, and they don't get it, because the mortality will be much higher. Let me tell you a story. It's about Canada. I was working in the middle of Canada. It's a big place, somewhere up there, somewhere around here. You know, it's funny because I was with my wife in British Columbia last week, and we were driving along, and I said, "Isn't it big, sweetheart? It's just huge. It must almost be the size of California." And then I looked it up, and British Columbia is almost 3 times the size of California, and it's only one of 10 Canadian provinces. It's a very big country. The distances are huge. And decisions that you make about transporting patients, just like if you were in somewhere like Tierra del Fuego, you know, the distances are huge to transport the patients, and when you make a mistake, you hear about it. This was the ward that I was working on. Canada is a little bit behind in the US. I had a patient that came in, he was a 42-year-old man, and he came in and he said that he had crushing retrosternal chest pain. And I did an EKG, and it showed the left bundle branch block. And I think some of you are younger than this. At that time, we didn't have TPA, but it became available in Canada a few years after the United States, and it was very expensive. Streptokinase was $200 US, and TPA was $4,000 US. It was a big difference. But when they first made TPA available, they told us it was for the really bad heart attacks in the really young people that really would benefit from this more expensive drug. And so I was from Toronto, and Toronto in Canada is like where all the snobs come from. You like that word, snobs? What's that in Spanish? I don't know. Yeah, they're all very snobby. I thought I knew everything. I was very smart. I thought I was very smart. I didn't learn how stupid I was until a few years after that. And this guy comes in, and he's, to me, with a new left bundle branch block and acute chest pain, only 42 years old, he deserved to get the new, better drug, TPA. So I went back to talk to him. I talked to the pharmacist, and he told me that his pain was getting a little bit better. And actually, to be honest, by the time I finally gave him the TPA, his pain was much less. But of course, we feel a real sense of urgency, don't we, to get the TPA in the patient. So we went ahead and we gave it. This was this is TPA. Okay, that's the drug that we gave. Now, this is the days before troponin. At that time, we had CK and CKMB, and you understand those are not as good, but those were the cardiac markers that we had. And guess what his CKMB came back the next day? Normal. So I got a call from the chief of staff of the hospital, and he said, Dr. SWADRON, tell me about the case you saw yesterday, because you just spent the entire budget of the hospital for 1 year on the one patient. And it looks like he didn't even have a heart attack, idiot. It's all true. I have to be honest, it's all true. And so the problem is that we're under so much pressure, especially now, when the government in the United States actually, I don't know if you knew this, but United States is really a communist country. I don't know if they told you that. It really is. In fact, the United States has the largest public healthcare system on earth, much larger than Canada. Medicare and Medicaid, which are the two governmental insurance programs in the United States, are huge. And they make up about 50% of all of the health insurance in the United States is government health insurance. That's the funny thing. When you see Americans debating about public and private insurance, they already have the biggest public system. Anyway, because the government controls the money, they're very strict with us now, increasingly strict. If we don't achieve a certain rate of treatment for pneumonia, if we don't get people to the cardiac cath lab or give them thrombolytics within 90 minutes, you've heard this stuff, we lose money. The pressure on us to do this right away and make a decision is enormous. The problem is that, as you know, most patients that are having chest pain and that have ST segment elevation are not having an MI. This chart shows the data. If you take 100 patients and you bring them to, and you study their EKG has ST segment elevations and they have acute chest pain, you can see that only 15% actually have an MI, and the others mostly have other things that don't need thrombolytics. What a quandary. So what I would say at this point, and you know, think about this case that I just told you about. His pain was getting better. And in order to meet the criteria to go to the catheterization lab, you have to have both the EKG findings and you have to have chest pain. He was stopping, his chest pain was getting better. And if I would have had maybe 10 or 15 more minutes, and I had given him some nitroglycerin, maybe, you know, have him in the bed with some oxygen, and his pain had gone completely away, he no longer would have been a candidate for giving TPA. And you understand when I say TPA and cath lab, I'm talking about the same thing, right? It depends where you work, which one you're going to do, right? Nod your head. Okay, good. I see at least one nod. So what I would say is that our own fervor for excellence, okay, for making these times look good is actually become our enemy in many cases. Because if we had more time, we could do a second EKG. We could give the patient some nitroglycerin. We could take a look at the situation a little more carefully. If worse comes to worse, and this is a big thing in the United States, we could take a history from the patient. But this is a last resort. And I'm not joking with you, because this is how it happens. And tell me you don't know what I'm talking about. Patients come in, they have the EKG, they have a chest, we go crazy, and we don't talk to the patient. You take a better history, you often find out that there's no need to call the cardiologist at 3 in the morning and the cath team, or to give TPA. Especially when you consider patients like we often see that have been having chest pain for 11 hours or 10 hours. Okay? What's the mortality of an inferior MI? What's the mortality? Well, it's 1% at this point, 1%. So say you have an older patient that comes in with an acute inferior MI, and they've had pain for 10 hours. The government says if you don't get them TPA within 90 minutes, for example, or 60 minutes, you're a bad doctor and you're not doing a good job. How much difference do you really think that those interventions make in someone who's been having 11 hours of chest pain, and already the mortality, I told you, is about 1%. So basically, we're driving ourselves crazy, okay? And so I really think it's important that we get rid of some of those strict criteria so that we can do a little more thinking, take a little more time with that woman or man and get a better history, and think more carefully about whether or not they actually need this important intervention. Okay, so that's the first part I wanted to talk to you was the no-code STEMI part. Now what I want to talk to you about, so I think that's really important, because I think if we want to avoid false activations, mistaken administration of TPA, we really need to take our time, okay, maybe 10 or 15 minutes. I think a second EKG and a history are imperative. Obviously, there's cases that, you don't think about it. I mean, the guy comes in a half an hour of pain, anterior MI, you're not going to be thinking too much more. You're going to get him straight to the cath lab or to lytics. What I want to talk to you about next is very, very important. This is the other side of the coin. These are patients that you don't recognize that they have an urgent indication for revascularization, but they do. They don't have the classic patterns, but if you don't recognize these atypical patterns, patients do badly. The first, and perhaps the most important today, is the case of the isolated posterior MI. Approximately 8% of all heart attacks are isolated posterior MIs. And as you know, you're not going to see ST segment elevation in these patients unless you put on the posterior leads V7, V8, and V9. And you know that you have to put those leads on when you see ST segment depression in V1, V2, and V3. Because just seeing ST segment depression, as you know, in V1, V2, and V3 could be anterior ischemia. It could be related to potassium. It could be related to hypertrophy. The fact of the matter is that unless you put those posterior leads on, you can't tell whether or not these ST segment depressions represent a true STEMI or whether they're just ischemia. So now when I put on leads V8 and V9, I see that in fact there is significant ST segment elevation. Only a single millimeter of ST segment depression in either V7, V8, V9, V10, or V11, you can keep going around, is sufficient criteria for emergent revascularization. Okay, everyone needs to know how to put posterior leads. It's very simple. Here's V8 right at the middle of the scapula, V9 between the scapula and the spine, and you can keep going. Why is it that we don't see ST segment elevations in posterior MIs? Is because look at how far the posterior wall is away from the EKG leads that we're putting on. It really is necessary to get right next to them to see what we need to see. This is actually considered to be a big problem in the United States. The mortality of isolated posterior MI is unacceptably high for the reason that most people don't understand what I just explained. Most physicians still are not quick enough to revascularize when they see an EKG that looks like this. Okay, forget about this part. When they just see a 12 lead that shows this, they're not quick enough to realize that that might be a posterior MI and get them revascularized. So the mortality is actually much higher, for example, than in the average inferior MI, and that's the reason. So that's the first thing. Now, that criteria already exist in the current American Heart Association guidelines for revascularization. It's already there. It's just a matter of us following it and being tuned to it, okay? However, this next pattern is not in the American Heart Guidelines, but probably will be in the coming year or two. And this is a very important pattern. It's the pattern of acute left main coronary occlusion. And it's characterized, remember what they told you about lead AVR, how it wasn't important? It's characterized by ST segment elevation in AVR. Remember AVR, the lead that goes into space in the middle of nowhere? Okay? Well, it turns out that ST segment elevation in AVR, and this is the important part, when accompanied by diffuse ST segment depression in the rest of the EKG, is a real emergency. It indicates a complete occlusion of the left main. They need to go immediately to the cath lab or receive TPA. So notice in this EKG that you'll see ST segment elevations in AVR and depressions in V2, V3, V4, V5, V6, 2, 1. Can't see anything in AVL here, and in AVF. This patient will die quickly without revascularization because you know the left main is pretty important. That's why they call it the widowmaker. Okay, I'm going to go through these, and then if there's questions, we'll have time. I think this time we will have time. This one is really interesting, and I think it also will be in the next version of guidelines for revascularization. Okay, these are all considered STEMI equivalents. Okay, just so we're clear. So this is called the De Winter ST complexes, and what's so interesting about this is that it's another example of a patient with no ST segment elevation whatsoever, only with actually ST segment depression, but when it's accompanied by these huge peak T waves, this upsloping ST segment pattern, especially here, concave upwards, if you can take a look at that, is associated with acute left anterior descending occlusion, acute LAD, left anterior descending occlusion. And these patients need to go straight to the cath lab. Some of you may be thinking, I thought Wellens syndrome was the one that was occlusion of the left anterior descending. You probably are familiar with this EKG. Okay, this is the patient that has Wellens syndrome, and remember, Wellens syndrome, you have deep inverted T waves throughout the precordial leads, the chest leads. Remember? That is also left anterior descending occlusion, but not complete. Sometimes 98%, sometimes 99%, but not 100%. And therefore, actually, as scary as this EKG looks, you don't call the cardiologist necessarily, you can call the cardiologist, but you don't revascularize at 3 in the morning. They go to the CCU and they're observed. I just want to make sure that we're all clear on that. In Wellens syndrome, there is a near complete occlusion. It is not a STEMI equivalent. They're likely to die without treatment in a few weeks, and they need to go to the cardiac cath lab, but they can wait till the next day. And just to drive the point home, there's Wellens syndrome. That's what it's like. You get a big plaque with a superimposed platelet plug, but no thrombus, no thrombus. Whereas in the De Winter pattern, it actually looks like this, with complete occlusion with thrombus. So that's a very important contrast between the De Winter complexes and Wellens syndrome. Okay, so Wellens is not, and De Winter's is a criteria. Next is this Garbosa criteria with left bundle branch block. And that's what I think a lot of people find the most difficult, and it's difficult to describe up on a podium in front of a lot of people. If you have any questions about it, you can come and ask me later. I'm going to show you a quick case. Actually, I don't know if I have that. Let me get the audio here. Oh, we'll see if it's working.
I just brought this guy from triage, the fast way. He's having chest pain.
Chest pain?
Oh, man.
All right, just a second, just hang on a second. Yeah, I want 1,000 apple stock, right? Can you do that for me? I'll be within a second. Yeah. Yeah, and also I need some, just a second, sir, just a second. Microsoft, I want you to sell that Microsoft stock again, all right? Okay.
You got to get me in.
SWADRON, how many times have you been here this week? Have you seen this guy?
Oh, man,
Every
it's
week?
not the same this time. It's
Last time I saw this guy,
It's
had
2 hours.
herpes, a huge herpes reaction.
Oh.
Just look, do me a favor, just go to White. Will you just go down the road to White tonight?
I don't have time to screw around this time. It's a real thing this time. It's precious 2 hours. It's real.
Go to White. All right, tell you what, just put him in a gurney, do a quick EKG, all right?
Okay, looks like your EKG is done. Hang on a second. Holy smoke. Have you ever been told you have anything wrong with your EKG in the past?
Oh, you know I've never had an EKG before.
Just check this out.
Okay, so whatever. So there we have a left bundle branch block. Okay, now let me this is a very interesting story actually. So, you know, up until now, 2014, it still says in the American Heart Guidelines that any acute or presumed to be acute, meaning you have no previous EKG, left bundle branch block, is treated with thrombolytics. Okay, you probably have learned that. In fact, they say that there's class 1A evidence for that. But you probably know, if you practice in the ER, that most patients that come with chest pain and left bundle branch block do not need revascularization. It would be a big mistake to give every single one TPA, even though the American Heart says so. Why did this happen? Why did this recommendation start that we should give all new bundle branch blocks TPA? How did it start? It started in the large Italian trials, cardiac trials. Do you guys remember that the country of Italy was used to study heart attack, the entire country, right? Every single Italian was enrolled in one of those heart studies. And based on that, they found, if you can follow with me, that patients with bundle branch block that received, at that time it was streptokinase, they had even more benefit than patients that had anterior STEMIs. That's where the policy came from. But the problem with this is that when those Italian doctors were taking patients into their study, they selected only the patients with bundle branch block that look sick, not all the patients that come in saying, oh, I have some piquetes, they have nothing, and they have left bundle branch block. They wouldn't put those patients in the study. So it seemed, from a selection bias, as if all bundle branch blocks were very serious and all needed to have thrombolytics. We have since learned, and this is through the research of our emergency medicine, not cardiology, our emergency medicine colleagues. This is Jeff Tabus and Jed Hollander, two emergency physicians. What we found is indeed most patients with chest pain and left bundle branch block are not having a heart attack, do not need lytics. However, if they have this Garbosa criteria, they are accurate, and we can give them lytics. So what does that mean for you? It means, number one, if a patient comes in and looks like a classic MI with a Levine sign, sudando, parece como mierda, you go and you give them TPA. That's fine. But if the patient doesn't look horrible and it's not obvious, then you apply the Garbosa criteria. If they're negative, you simply admit them to the hospital and continue to measure troponin, consult the cardiologist. If the Garbosa are positive, you're going to give TPA or activate the catheterization lab. Does everyone got that? So what are those Garbosa criteria? Basically, there's two criteria. One is inappropriate concordance. Normally in a left bundle branch block, you should have the ST segments on the opposite side of the neutral axis than the QRS. So here you see that the QRS is negative and the ST segment is also negative. In a patient with a left bundle branch block, that indicates an MI. In this lead here, you can see that the patient has a positive QRS deflection, and the normal pattern, as you can see, would be for the ST segment to be depressed on the opposite side of the electrically neutral zone, and yet it's on the same side. This is another example of MI, and the name for this rule is inappropriate concordance. Concordance means that these things are on the same side, but the QRS and the ST should be normally on opposite sides in a left bundle branch block. Another criteria is when they do have appropriate, the QRS is appropriately opposite, as you can see, the QRS is appropriately opposite to the ST segment, but it's exaggerated. It's more than one full box. It's a very, very big, or what we call excessive discordance. This picture shows in a little, I think, easier to understand format, this Garbosa criteria. This is a money slide. These are the three patterns that you're looking for that indicate a likely MI in a patient with left bundle branch block. Some people have been very negative about this. They have been, oh, they're not accurate enough. Well, let me ask you something. How accurate, how specific was ST segment elevation on the EKG for myocardial infarction? What did we say? 15 out of 100 patients only. This is actually much more accurate than a normal EKG ST segment elevation. These are actually very good criteria. So if you find that confusing, we all do when we first hear it, and we can go over that again afterwards. The last thing I want to share with you, the fifth criteria for activating thrombolytics or cath lab is very interesting. It's a story that is still being written, and I don't have all the answers for you, but it's very interesting. A patient comes in, maybe he's a young man, maybe he collapses with an MI. He has VFib or VTAC, and you resuscitate him, you bring him back. What you need to understand is if that patient went down with chest pain, and that's a young person, and that's a person that looks like otherwise they would be okay if it wasn't for their cardiac arrest. You know, they've got good tissues, good brain, good lungs, good kidneys. That's what we call the heart that's too young to die. You've heard of that. Those patients, when they come to the ER, it doesn't matter, it doesn't appear to matter what the EKG shows. So let me say that one more time. A patient collapses, they have chest pain or shortness of breath, and they collapse, and we do CPR, and we defibrillate them, and we get back a rhythm, okay? When they come to the hospital and we do an EKG, it doesn't matter what the EKG shows, they still might have a 100% occlusion that needs to go to the cath lab. Up to 40% of the patients that have a 100% occlusion of their coronaries after they collapse without pulse do not have a STEMI pattern on their EKG. So what does it mean? It means just what I said. You have a young person who collapses from a heart attack, they get them back, and you do an EKG, you still call the cardiologist, you still call the cath lab, because it's a good chance that you can save that life. It's a good chance that they really have it. So here's an example of a patient who collapsed and the EKG was almost normal and they had a complete occlusion of the LAD. So those are the 5 criteria that I wanted to emphasize that you shouldn't miss, and we'll make sure that that's available to everyone with all those EKGs so you know about them. And hopefully with that information we can be more accurate and get the ones we need and not get the ones we don't need. Thanks very much.
Más preciso. Muchas gracias, doctor. Muchas gracias, doctor SWADRON. Ahora queremos dar la bienvenida a un nuevo invitado, urgenciólogo también, que nos visita desde Los Ángeles.